Thank you very much to Tanja for joining us. I'll quickly introduce Tanja before we hear from her. So we are very lucky to have Tanja talk about this particular topic of interest to many of us. Tanja Hirvonen is a registered clinical psychologist. She specialises in Aboriginal mental health, social and emotional wellbeing, trauma and self-care for health professionals. She holds a clinical master's in psychology from James Cook Uni and has done a research on mental health knowledge and attitudes towards suicide in Australia. She's also done her honours in psychology from the University of Southern Queensland, and that was around the structural validity of problem-solving inventory in Indigenous Australian populations. So she's got expertise in trauma, suicide prevention, and has been working primarily with Aboriginal community-controlled health services in Australia, and focusing on workforce development, training and support for health practitioners. And she has extensive experience in culturally responsive training, community engagement, and trauma-informed care. We're really looking forward to hearing from Tanja today. She's done a lot of work in influencing policy outcomes, looking at developing culturally tailored therapeutic interventions, engaging with communities about improving health and wellbeing, and she's also an early career researcher and has contributed to grant proposals focused on Indigenous social and emotional wellbeing, trauma and suicide prevention. She's a polished presenter and has presented on topics such as trauma, healing pathways and self-care for health professionals and the Indigenous models of wellness. So thank you so much, Tanja, for joining us, and I'll hand over to you now.
Thank you, Matthew, and thank you, Susan, for the invitation. I just wanted to acknowledge the sovereign owners of the lands on which we're all dialing in on today, acknowledge elders past and present, acknowledge any other First Nations or Indigenous people in the room and your ancestors, and also the allies that work alongside us in this work, so thank you. Yeah, no, thank you for this introduction. And look, I did have a little chat with Susan for such a complex and multifactorial, multifaceted concern and it's been quite significant. You know, this is probably an entree. You know, some of this work, because of its complexity, will need the time that it deserves and respectfully deserves. But this is still important, what I'll share with you today, that you can definitely take away, but knowing there's still a lot more. So I'm just putting up front the limitation to having this on Zoom and having short time, but it's still better than nothing. But as long as you understand that there's a lot more behind that needs to be, you know, learned or understood in the work that you do. Yeah. So just an overview. Thank you, Matthew. There was a little part to the conversation. I've actually stayed away from suicide work. I had lost some important members of my family, so I actually made an intention not to work in the suicide space, but it kept following. So you know, again, armored up, learned as much as I could, and it keeps popping up. So I thought, oh well, I'm going to have to get my teeth into this topic. But on top of the topic was around, particularly in First Nations populations, the impact of trauma and the environment in which we live. So just at the top of this conversation is not all presentations of suicide has been a person with a true mental health diagnosis. So just understanding that sometimes we actually might not have those presentations, or people coming into the hospitals or to GPs or psychologists, that it can be part of what's happening for them in their environment. So I just wanted to share that. So right now, the context of suicide for First Nations peoples in Australia is again, the data shows that we have higher percentages of people ending their lives to suicide when compared across non-Indigenous populations. I can get all the statistics for you after the presentation. We also know that our Aboriginal and Torres Strait Islander men at a certain age point between the ages of 15 and 19 are most susceptible to that. But in the same breath, the landscape is changing. It's just not hit the literature just yet, all the journal articles, but we are seeing young people, straight A students, kids are very, very successful, have wonderful relationships with family and community, doing exceptionally well. We think they're going to be the role models, ending their lives to suicide. And we're seeing younger populations, and we're also seeing an increase in females across Australia. What is also interesting in the research is the number of suicides after a natural disaster, and Australia has had quite a significant number of those, or a significant traumatic event. And let's just pluck one of them for interest's sake. Let's just look at the pandemic as one, and another one would be, if we plucked one out, would be the referendum or the increase in racism. And in simultaneously or in parallel, this is across all young populations, is the increase in bullying on social media. That's also impacting on First Nations populations. The added kicker to that is some of the bullying is based on colour and race alone. It's just an added compounded factor that we're saying, yeah, all kids are subject to bullying on social media. The bullying for First Nations people in their own country of origin is based on their identity, and it can really impact on that self-esteem and the identity, and when particularly in those formations, developmental stages as young people. So we will touch. Without getting into too much into the statistics are high, they're worrying, and they're significant. We will talk about it, and then we'll actually start to talk about what can we do. It does matter where you live. So once you start going out to more rural, remote areas, the numbers climb, and there's many factors for that. One is the lack of services, the lack of opportunities, and pressure cooker environments. When there's disadvantage. We hear that particularly for island communities, how impactful that can be. So it does matter where you live. And it does matter about the services that you receive. So I've got slides, but I might share them with Sue to share them with other people after. When an Aboriginal and Torres Strait Islander person enters a service, we're expecting a service that is helpful, not harmful. We do know that with just using a clinical approach, or just the biomedical model or the mental health model, it can be largely ineffective culturally if we're not also looking at the relationship and the environment, et cetera, et cetera. So what I'm talking about here is whether or not some of the interventions that are applied are culturally appropriate. Okay. So what I mean by that is, like, we'll grab this young person, throw them in the room and do 10 sessions of CBT and she'll be right. Bob's your uncle and we'll catch you later. That type of intervention is probably highly unlikely to be helpful. Although I will not lie, CBT can be very helpful in certain circumstances, but you've got to actually meet the client where they're at. So looking at what the interventions and the solutions should be driven by the community themselves. And we do have a beautiful organisation called the Centre of Best Practice in Suicide Prevention, headed up by University of WA, Professor Pat Dudgeon and Professor Helen Milroy, who talk about many of those solutions and strategies. So communities have done a lot of work in this space, sadly, because we've had to. But there are a lot of gold standard best practice solutions already established. If we're working, I didn't get to check whereabouts everyone is from, but if we're working clinically in a space, as long as we're doing it in conjunction with whatever services are operating on the ground, that's quite important. Or if we're commissioning funding, that we're making sure that it's going to also be culturally effective and trauma informed. Or if we're in a space where we're driving policy, that we're considering the context around the type of work that we're supporting, and that the policies do consider Indigenous ways of well-being, such as the social and emotional well-being model. And with that, I just want a show of hands who knows about the social and emotional wellbeing framework or model by, yep, great, Dr. Graham G. So that was a direct, that model was developed as a direct response to the biomedical model being largely good, but not as effective if we looked at, social and emotional wellbeing in a holistic way. They're the other frameworks I want to talk about. We've got the social emotional wellbeing framework by Dr. Graham G, Professor Pat Dudgeon, Kerry Kelly, Amanda Hart, and Dr. Clinton Schultz. So that's very well known. We've got the Gaia Dewey Declaration, and we've also got UNDRIP, which is the United Nations Declarations of the Rights of Indigenous Peoples. So they're all the reasons why we need to work in a culturally safe and culturally effective manner. For those organisations or those clinicians that are regulated by APRA, we've also got cultural safety now named in national law, which means that right now, if we're practicing clinicians or you look after practicing clinicians or there are practicing clinicians out there, they actually have to work in a way that's acknowledges Aboriginal and Torres Strait Islander ways of knowing, being, and doing. We now, going through, declaration, I'm a clinical psychologist, so going through psychology, we didn't get to see ourselves in the curriculum. Going through clinical assessment, going on to do masters, weren't able to do assessments that were culturally validated. Didn't have many tools and measures and screeners to culturally, like that actually talked about depression or anxiety. Yeah. So a lot of the Aboriginal and Torres Strait Islander work that you're seeing now are from the people that have been through mainstream sectors and systems and disciplines and come out the other side and developed it on the other side. And right now we're in a renaissance, or we're in not a renaissance, we're in a time where we're talking about decolonizing the system or the sector. So that's happening in psychology. I believe it's happening in social work. I believe it's happening in the medical curriculum. So with that, it doesn't mean, we have to get rid of everything that mainstream society has developed. It's absolutely not that at all, because it's amazing and it's great and it's got place and efficacy. It's actually also making space for Aboriginal and Torres Strait Islander ways of knowing, being, and doing, just at the same table, and making sure that it's part of the curriculum or part of the knowledge. Yeah. So it's not getting rid of everything that's mainstream. It's actually saying, hey, mainstream, that's deadly and that's amazing, but hey, we've got this other work here that we want to put at the same table and have similar value for. In psychology, we had the apology to Aboriginal and Torres Strait Islander peoples, and that was back in 2016 in Naarm, which is Melbourne. And that apology was helpful because it did talk about our disciplines in the health sectors, and everything that we did to minimise mental health and suicide were actually not effective. In fact, they're probably harmful. Yeah. So there was a line in the sand to say we can do better. And so some disciplines have acknowledged that, and not for guilt, not for finger pointing, just saying, put a line in the sand and we know that we can do better. That's simple as that. So a lot of work is going on right now to do better. I've talked about largely why we are where we are. The numbers of suicide, I would say, at a time had stabilised, but now we're seeing increases again. quite significant increases in the First Nation populations. In fact, we've got closing the gap measures and targets. Suicide for Aboriginal and Torres Strait Islander peoples is not closing. So you hear about closing the gap, not closing in with suicide. So we have to acknowledge history to again put that line in the sand and say, okay, what are we going to do going forward? We actually have to armor ourselves up. So I did give a very, very short version of why some of the reasons why we are where we are. We haven't even spoken about colonization. We haven't even spoken about intergenerational trauma. But they're all big factors in this and why we are where we are today. So we can't ignore history. We can't just use deficit-based approaches. We need to look at complementing work that's already been done because the solutions are within the communities themselves. So fly-in and fly-out models can be helpful if they're scaffolded and looked after correctly, and really, when I mean scaffolded, that it's the community's ready, the community's acknowledging the model and accepting the model for what their models might look like. Suicide, when I first started researching suicide, I remember reading something saying one suicide affects 8 people, and I knew straight away that that did not represent the reality for Aboriginal and Torres Strait Islander people at all. The literature then started to say most Aboriginal and Torres Strait Islander people have lost someone to suicide or know of someone that they've lost to suicide. We're actually now in the space where many families have lost more than one. So we've moved past one, and we've got more than one. And I'm actually thinking now for mainstream populations within Australia, most people, so suicide is not just an Aboriginal and Torres Strait Islander concern. It's also a concern for all populations and cohorts like, construction industry, first responders, et cetera, et cetera. So, but it's still a very sensitive topic. Very, very sensitive topic. I have to underscore the importance of that. There are still communities that are ready to talk about suicide. Suicide took a long time to talk about, but there are some communities that have a great deal of readiness and some people that are probably still uncomfortable with discussing suicide. What does work? I talked about the community-based solutions, cultural safety, trauma-informed care. I have had phone calls from psychologists saying, oh, we're going to this community. We're going to do all these assessments. Can you tell us the most appropriate assessment to use? And I said, yeah, sure. Which community are you going to? Oh, going to such and such. I said, have you ever been there? Never been there. We're flying in, we're spending a week, and we're flying out. That's not the way to do business. That's culturally unsafe behaviour. Relationships are key. It's the approaches that you have. You can have 100 letters after your name, have the best culturally validated tool in your toolkit, know the community very, very well, know all the history, probably even speak a few of the words, know who to go to when. But if your approach is not there, and so when I say approach, the soft skills, the trusted space, you're probably going to do a little bit more harm than good, yeah? So it's actually that you are knowledgeable about the history and the environment, so AKA cultural awareness, that you actually have the skills, you've developed the skills. And the third part is that you actually have embedded cultural safety within the work or your program or what you're looking after as an organisation. So it's about relationality and those long-term relationships and not working for and on. It's working with, alongside. Making sure that you're connected with the community, with elders, cultural advisors or mentors, and community members as part of that work. So you're armoured up not only intellectually or theoretically, but you're armoured up with the beautiful people around you to do the work well. There are a lot of protective factors, and you might also be familiar with the Shonla Lalonde work or the research that they conducted. Shonla and Lalonde did some work around what the communities or I think they mainly looked at countries that had been colonized, but the communities that had low numbers of suicide were the communities where self-determination, where people had ability to determine their lives, were the communities that did not have the significant numbers of suicide. So self-determination and the ability to live the life as you wish to live your life is a factor. Yeah. Other protective factors are all those connection domains that are in the social emotional wellbeing framework. So connected to country, culture, yourself, your body and your emotions, spirituality, ancestors, etc., country and language, and that there is strong community leadership. There's pride in your identity, that you're actually accepted and valued as an Aboriginal and Torres Strait Islander person, and that your services are culturally safe and not harmful. Cultural safety, yeah, like I said, the layers, you've got the cultural awareness, knowing exactly what's happened on that community, who to talk to, where to go, who the elders are, what's the language, what's the traditional owners. Cultural competence and cultural responsive is the skills that you develop, the skills and the competence to be working there. Even me as a Jari Bonobo person, I have to develop the skills to work on Larrakia country and have mentors and supports there. But cultural safety is looking at all of the policies and procedures and the processes at play. It's another level, and cultural safety is determined by the person or the recipient of the service. If you decide to work with the community, it's co-design. It's kind of just another word, but I think authentic relationship would be a preferred term, that you're authentically engaging with the community. There's got to be time and trust, time for trust and relationships to build. And authenticity again, authenticity. And also being mindful of what you do with the work, even if it's in research or program development. What are you doing with the stories that you capture as part of your work? Where's the data sovereignty? Do you have authority to share those stories elsewhere, or endorsement? And do you keep checking back in with that community as to what you're doing with their stories? And again, some of these, the reasons, well, some of the things that I've talked about today are not just because I thought it was a great idea. It's aligned with national policy and international, UNDRIP, international, I guess, frameworks, and also national frameworks that a lot of people have spent a lot of time in working through. We also have national suicide prevention strategies, and again, all the information about why or where we are now has been from a lot of work that's been done for the last 10 to 20 years. I'll give you a bit of a story with the cultural safety definition for APRA. That was about 3 or 4 years in the making. So none of this work is done within 1 or 2 months. It's a lot of blood, sweat, and tears to get there. If there's anything that I'd share, that it, as in a call to action, one is that it's still devastating communities. We see a suicide now impacting so many people, and it can impact, so we could lose someone in Queensland, but that reverberates across Northern Territory and Western Australia with all the connections. There's such a complex web of relationships that one person can have, that though the impact of the collective trauma for a loss is immeasurable. And then we lose one, and then we lose another one, and then we lose another one. So there's also an inability to grieve properly for a particular person when there's already then somebody else who's actually passed on. Even if it's not in the immediate family, it can be in the extended family group, or even in the environment or in the community. Yeah. So centering First Nations knowledge and histories is very important. Yeah, but that gives me about half an hour. So thanks, Matthew. And I just wanted to open it up for some questions. And please, I do want this safe to be, this place or this space to be, there is no no awkward question. So it's a safe space. So even if you think, oh, I'm not too sure if I should ask that, I encourage you to ask that or send it in a message for later, and I can give that back to Sue.
Floor's open for questions. Go ahead, Kathy.
Thank you so much. I've been typing vigorously some of your thoughts. I just feel like it's just wonderful to hear the way that it's all come together. I'm really interested in the difference between cultural responsiveness and cultural safety. I know Marta is as well. And one of the things that is often at the front of my mind is that we have in Southern Adelaide around about 5% of our consumers identify as Aboriginal or Torres Strait Islander, and we have 0.6% of our workforce identify as Aboriginal or Torres Strait Islander. I am often talking to teams and team managers around, do the clinical yarning module, do this piece, look at IRIS, the Indigenous Risk Impact Screen. This is something you can do. Look at the social and emotional wellbeing. I'm trying to educate, but I know that for good cultural responsiveness, the best practice is to have an Aboriginal person delivering a service. What's your thoughts around where we can go from here? Because suicide safety planning isn't fit for purpose for an Aboriginal person, and that we're doing for everybody else. And we just don't want people to keep dying because we're getting it wrong. So what are your thoughts?
Well, I think it's about the process and the policy, and then what your remit is as well. I guess if you've been so it goes down to your guidelines within your organisation, and where you are. Like if you're in an Aboriginal medical service or a local health organisation or whatever. But it does go down to what your risk assessment looks like. Like risk assessment's still important, but how we determine risk. Oh, I'm going to be a bit naughty here, so I'll share. I had to do a expert witness statement, so I don't have to tell you what state or territory. And I got to watch videos on a very tricky situation about how an agency was doing risk assessments, and so we asked the questions: have you tried to end your life before, or have you had any family members that have tried to end their life, or have you had anyone that's ended their life? But it was done in the environment where it's in an open plan and it's standing up. It was more like an intake. So the actual steps to even have that conversation has to be considered. So without looking at the screeners or the assessment tools, they can come later. It's actually about how we actually approach suicide first, and what we do, and how much we value that one conversation. So not in an intake way, but in a way, look, I want to talk about something very, very, so conversation starters is probably the best way. I really want to talk to you about something that's really, really important, but it is also sensitive. So I'm just going to say this as gently as possible, but again, I wouldn't even go there until we're probably already half an hour in of building rapport. So there's so many checks and balances before we get to what you were just sharing about how do we then ask the questions or talk about this actual topic. What are all the steps before we get there? And how is your organisation even seen in the community as well? So there are all those confounding variables before we actually even do the actual work. Again, I'll share something with Sue, because there was some work done with Menzies at the Royal Darwin Hospital, and it was like a psychosocial approach to suicide risk assessment, because the questions nearly all the same, but it's how you get there.
Thank you.
For them to say, yes, I did try to end my life, or if you did not talk to me today, I wasn't going to be here tomorrow.
I think that's really helpful. And I guess what I'm hearing as well is that people are lucky to have 30 minutes full stop with somebody. because of the pace and the pressure in the local health network.
Pushback.
But it's about the pushback, yeah. Thank you. And that Menzies document would be good. I've seen a couple of the Menzies things like the Stay Strong app and the care plan, but that resource sounds a little bit different to what I've seen. I don't know if Marla's seen it, but yeah, that
pushback, because when you're sitting in a coronial, you will get asked why this person that you knew in this age bracket, and you know of the numbers of suicide, that you knew that, and you still only spent 20 minutes with that person. So my beautiful advice is to push back.
Thank you. I'll quote you.
Good advice. Thank you, Tangerine.
Hi, Tanya. Thank you for that. That was a fantastic presentation. Hit the nail on the head with everything. But just when you mentioned like the referendum and the effects that it had on our communities, this business of welcome to country is really blowing up on social media, and it's really affecting, I think it's possibly a lot of older Aboriginal people, the young ones to a certain extent, but it's having that effect as well. And it's like, why don't they just stop? It's just, yeah, we're so undervalued. It's unreal. I just want to put that out there so everyone knows that, yeah, the Aboriginal communities are feeling the effects of this now.
Well said, Tangerine, and thank you. And look, I'm not tearing up here, but definitely crying on the inside. Just another layer that we have to contend with. And hey, it's just before the election, so let's just weaponize Aboriginal people again. We won't talk about suicide, but we'll talk about, do we or do we not do a welcome to country? We won't talk about the horrifying chronic health, but let's talk about if we have this flag or not that flag. So our issues are significant, and we're not seeing it on the national agenda. But I'll just say something. Those beautiful elders, for Auntie Joy to have that experience in Victoria was absolutely shocking. And you're right. So Tangerine brought up something like a collective grief and a collective trauma that we're all feeling because we're part of a collective. Just because it happened in Victoria doesn't mean the Northern Territory and the Queensland mob aren't feeling that pain on the inside. That's a case in point, collective trauma. And we want our allies. We're our allies to speak up, and that it's not just our fight. But again, yeah, we're waiting to see it being weaponized. We're part of a respective debate. So Gaia Dewey is the mental health peak for Aboriginal and Torres Strait Islander mob. Duralee, I'm an interim CEO there, and Gaia Dewey, Duralee, a couple of other Aboriginal organisations, AIDA and maybe IAHA, got together and said that if you're going to talk about Aboriginal issues, not to weaponise and to use, not do any misinformation, and to talk about issues that matter. But Tangerine, just the first point you made about racism. So before the referendum, I do know of groups working with young people where they were already, I'm talking about young people where they are already at risk for suicide for issues around disadvantage and racism. And then we had the referendum just throw a little bit more fire on a bonfire. And so we had a lot of Aboriginal and Torres Strait Islander people experiencing racism we've never seen before, or we knew it was there, but it was more overt. It's becoming overt. But I had clinicians really, really racking themselves with anxiety about the people they were working with for what they were actually seeing. So this is not just an Aboriginal problem, team. Our clinicians are working with these beautiful young people and are actually stressed and anxious around how best to support in this environment.
Yeah.
Well, thank you, Tangerine. Sorry, I didn't mean to cut it off, but I think it really is causing people real and current pain. And I acknowledge the comments in the chat that are sort of supporting this situation as well. So thank you very much for your statement, for your comment there, and for your response, Tanya. Wendy, you have your hand up.
Thank you. Thank you, Tanja, for a most appropriately challenging presentation with us today. There are two things that came out to it. I'm not a clinician, but I manage our zero suicide implementation team in Metro South in Brisbane here. One of the things that occurred to me, you mentioned a whole range of protective factors, and I guess to me the challenge is, how do we factor in those protective factors if, say, for example, a young person or whatever people's age might do present to our emergency departments or whatever. And it's not so much a question, Tanja, as much as a challenge of thinking, how do we factor those in more comprehensively, and knowing what those protective factors might be. So that was just a comment, really, Tanja. Secondly, and again, this is probably more a comment, in our service a couple of years ago, specifically related to institutionalised racism, we had a program delivered called Courageous Conversations Around Racism that some of our staff at the time delivered, and in fact one of those is doing her PhD on the impact right now. So that and I personally did the training, even though, well, yes, it is related to suicide, isn't it, which is exactly what you've been talking about, but that's been a program that's been quite useful in going deeper around the issue of racism, particularly in healthcare. So thanks, Tanja, for your presentation.
Thank you.
Thank you, Andy. Sue.
Thanks, Tanja, very much. That was great. You did mention that cultural safety is determined by the person with whom you are working. Can you help? Because we're all of the players today are in health services. They're in public health services, or public hospital and mental health services. How does one go about working with someone in a short period of time to understand what they will determine as being a safe place for them to be? What are the sorts of things that can be done?
Yeah, no, thanks, Sue. It's a good question, actually. So one of the, as a clinician, if you're working individually, is to say either I'm Indigenous or this is who my mob are, or or I'm not part of your mob, but I'm from, I was born on the sovereign lands of the Kalkadoon people or whatever. And look, I'm not, and this is my first time working with an Aranda person, so I want to make sure that I'm doing the right thing by you. Again, Kathy, setting the scene, just putting it all there. It's all the informed consent kind of thing. This is an individual. I'm just operationalizing it individually. And then it's like, you know, I'll do my best. And do you think you would like to work with me? I'm not pushing myself onto that person. Would you like to work with me, knowing all of this? I've had to do this in prisons myself, and I've had to work in male prisons. Anyway, yes, if it's informed consent, yeah, we can work together. They're not to teach you. They're not in the room to teach you all things Aboriginal, but you are to check that you're actually doing the right thing. And so you know, the 5 minutes before the end of the session, are you going to come back in 2 weeks' time or 1 week's time? Are you feeling comfortable enough to come back? And did I do okay or anything like that? It's sort of self-serving, isn't it? It's more like, were your needs able to be met? We're able to meet your needs, and is there anything that I could do more of, less of, or differently to make sure that you're okay? So it's just that regular checking in. That's that individual stuff. But then when you're looking at a team, you're looking at what are the evaluation or the mechanisms for feedback to be continuous. So cultural safety is always continuous growing and continuous learning. And then community-wide, like, are you meeting with the community? You should already know. Your evaluations or your screeners or your measures or your surveys should already be backing up what you already know if you are connected with community. You should already know that, you know, I don't know, that you've got 6 or 7 Aboriginal and Torres Strait Islander people on the books, or that when you have community yarns or gatherings, that the Aboriginal and Torres Strait Islander community are coming willingly. Or the best compliment is when one of the people that you're working with refers one of their friends or family members. That's the biggest, I guess, accolade you're going to get. It's not going to be that you're going to get a gold star review and a Google review. It'll be that they recommend you with their friends and family. Yeah, but good. You're individually checking in, but all your mechanisms for that evaluation and feedback are important.
Thanks, Tanja.
Thank you, Tanya. Linda.
Oh, hello. Please let me know if we need to wrap up soon. But I had maybe one of those awkward questions that you talked about. So it's not in relation to my current context where I work now. It's previous contexts I've worked in, I think mainly. I really appreciated your advice and talk, by the way. That was really helpful. I've written down all of the resources. But yeah, I guess in our roles, I guess sort of a little bit one step back from the clinical coalface, we're sort of developing pathways, care pathways and what have you, for people at risk of suicide, you know, inclusive obviously of our First Nations consumers. And I guess with all our goodwill of wanting to have something that is, you know, is fit for purpose for the communities within our, you know, area and catchment, it can sometimes be quite challenging, I think, because there's a number of, I guess, organisations, a number of different staff who were Indigenous within our services. And I had a particular circumstance in my last organisation where one group of Indigenous staff and another group of Indigenous staff had just over many years kind of had a lot of conflict to the point where they didn't feel safe with each other, talking in a room and, you know, contributing to developing, you know, our suicide prevention approaches. And also, sorry, I know this is a long-winded question. Also, I'm aware there are organisations as well, you know, in our area. There's IUE, you know, there's our Centre of Excellence within our mental health service. They're on the ground, you know, health workers. And so I'm just wondering about your thoughts about how we can contribute as outsiders in some way to these communities to kind of try and bring them together so that we can have a conversation, I suppose, start conversations, or not bring them together because that doesn't feel safe, but how we can manage that, I suppose. Does that make sense? Yeah.
Yeah, it's a tricky one. I guess, again, it's dependent on the community and how long that, you know, there could be that intergenerational conflict that's probably happened before our time, but it's about the invitation to be involved as well.
Yeah, many invitations just declined, I suppose, because that's lack of it's an organisational context. It's a lack of safety in the organisation, and that's really the system's responsibility that's created this lack of safety for people who work in our organisation, Aboriginal and Torres Strait Islander people who work in our organisation in various roles, to be able to work together in a safe way, I think, you know. Yeah, it's
a
quite
tricky
sad.
one.
Yeah.
But that can also, just on another level, the more that we are, the relationships are not harmonious. There's no judgment or no finger pointing.
No.
When the relationships are not harmonious or collegial, it can have an impact on the ability to do the work.
Yeah.
And so actually talking to the elders and if, you know, again, there could be a moment when the elders actually might say, we might need to do things differently or something like that. But I think it's still based on an invitation.
Yeah.
So an invitation to support that collegiality is what I'm talking about.
Okay. Yeah. I remember racking my brains too. I just work with them all separately, you know, and because I want their input. They're all wonderful and they're all, you know, I'll just work with them separately. And so they don't have to come together, but I can get that wisdom and knowledge from them to create, you know, something that's respectful.
But that's a good question to ask actually the group. So then you're not making the decisions yourself. You're allowing the community to self-determine what they would like to do.
Yeah, that's really helpful. Thank you.
Yeah.
Right.
I don't know if other people have experienced similar things. Yeah.
No, but thank you for feeling comfortable and bringing that up to Linda. Thank you.
Well, thank you, everyone. And that sort of does bring us to the end of the agenda time. Unless there's any other burning questions, I'd invite anyone to ask any further questions through the chat or through Sue or myself for passing on to Tanja. This is, as you sort of said at the start of your presentation, this is such a wide scope of discussion, and I think we've dipped into just a part of that today. But I would like to very much thank you, Tanja, for your time, for your expertise, for your willingness to share your experience and journey in this space, and acknowledge your wisdom and your people. And thank you for that.
You're welcome.
And just a reminder, Matt, that we have recorded Tanja's presentation, and so that will be available on the Teams group, and also with Tanja's approval,